afternoon, or evening, depending on where you are. My name is Nan Freund, and on behalf of the Association of Educational Therapists, it's my great pleasure to welcome you to our webinar, Complex Kids and Medication, a conversation with Dr. Jagan Chilakamarri and Laura Doto. The Association of Educational Therapists is the national professional association that sets standards and ethics for the professional practice of educational therapy and provides ongoing professional development for its members and the public. AET offers a variety of professional development programs, including webinars, study groups, regional workshops, and a national conference that enable members and the allied professional community to stay up to date about the latest research-based findings in the fields of education, psychology, and neuroscience. Our 2016 national conference will take place in the San Francisco Bay Area in October. It will feature Dr. Daniel Ansari, who heads the Numerical Cognition Laboratory in the Department of Psychology at the University of Western Ontario, and Dr. Guinevere Eden, Director of the Center for the Study of Learning at Georgetown University, where she studies the brain bases of developmental dyslexia. And now it gives me great pleasure to introduce today's speakers. Dr. Jagan Chilakamarri works closely with educational therapists in his private practice in Atlanta, Georgia. A board-certified child, adolescent, and adult psychiatrist, and a fellow in the American Psychiatric Association, Dr. Chilakamarri is the medical director of the Atlanta Psychiatric Institute. He completed a National Institute of Mental Health Fellowship in Autism and Developmental Disabilities at Yale Child Study Center, and 2 residencies, one in psychiatry at Yale and the other in child and adolescent psychiatry at St. Louis University. In his private practice, he's currently involved in seeing patients with complex psychiatric diagnoses and is a member of the International Mood Disorder Network. Laura Doto is an educational therapist who wears 2 hats. She is the director of academic support for Montclair Kimberly Academy in New Jersey, where she coordinates policy and procedure for accommodations, learning support, and curriculum planning. With a master's degree from the University of Chicago, Laura practices educational therapy in the Chicago area, working primarily with college and graduate students through Lauren Academic Services Incorporated. She is also on the AET Board of Directors, where she serves as program director. We're most fortunate to have Laura and Dr. Chilakamarri with us today to help us learn about considerations for medication for complex youngsters who present with 2 or more comorbid conditions. Please welcome Jagan Chilakamarri and Laura Doto.
Thank you, Nan. Welcome everyone to this webinar. I'm so excited to be having this conversation with Dr. C, as he likes to be called by many of his clients and patients. I just want to give you a heads up to our agenda over the next hour. I'm going to try to keep track of time so that we can make sure to get through everything. Most educational therapists really like to attach information to cases, so we have built in a case example. Before we get to the case example, however, I am going to be asking Dr. C questions about general developments in psychopharmacology, and then we'll talk specifically about how he collaborates with educational therapists and how educational therapists might consider collaborating and how valuable that is when they're working with a psychopharmacologist or psychiatrist. So without further ado, let's get started. My first question, Dr. C, is related to some of the most common first-line medications. We're going to be talking about ADHD, anxiety, depression. So if you could just kind of provide us with an overview of some of the current medications that are first line and any new developments that have been coming down the pike.
Well, thank you. First of all, I want to thank you, Laura, and also Nan, for inviting me to join in this. And I'm pretty excited to see you all. And good morning, good evening, and good afternoon, wherever you are. So I'm going to briefly start with first the ADHD medications, because I think that's most of you, basically are more familiar with that aspect of, treatment aspects. And then I will talk about more about the antidepressants and antipsychotics and the other stuff that are coming up new. I don't want to go into deeper into the psychopharmacology, but I will give you a brief overview so you have a better understanding of what's new in the field and how this is revolutionizing the way we are treating the kids in the future and now. So before I say anything about the ADHD medications, so fundamentally there are two classes of medications. One is as we all know, the class of medications known as Ritalin, and the class of medications called Adderall. So the class of medications of Ritalin, basically the ones that basically are more or less like Ritalin, Focalin, and then the Concerta, Metadate, Ritalin LA, and then the Quilavant XR. So there's a lots of different ones go under the class of that. So I will be giving you a couple of newer ones just in a second after I complete the Adderall class. So the Adderall wise, the most popular ones are really the old one is the Dexedrine, then came the Adderall, and then the Adderall XR, then came the Vyvanse. So these are basically a bit of a manipulation of the drugs in a sense to make them kind of like they tweak the medications and they came up with the new options of drugs. For example, I'll give you an example, would be like a Ritalin goes into the body and breaks down into dexmethylphenidate, which is called Focalin. The same thing with the Dexedrine is a D-amphetamine, whereas the Adderall is the D and the L-amphetamine. So the Adderall is a 3:1 mixture of the D-amphetamine and the L-amphetamine. So they came up with a new drug called Evykio. I'm sure you heard about it. It's a drug used from 2.5 milligrams to 10 milligrams. It's a 50-50 combination. What that basically means is it's a 1:1 combination of the L and D changed from being 3:1. The idea is that increasing the L sometimes can improve the focus without increasing the, usually the speculation is that the D-amphetamine is basically more to hyperactivity, impulsivity, and the L has a bit of a better effect on the focus. So by increasing the L, can we get a bit less of the anxiety and a bit more on the focus aspect of it? The most popular drug everybody knows is the Vyvanse. It's the list. The advantage of the Vyvanse is that it is a bit more prodrug. What is a prodrug basically means it goes into your stomach and break down into the active component. The idea of developing the Vyvanse was that to reduce the risk of the abuse potential and trying for people. So Vyvanse got a new indication now for the binge eating disorder, as you all know probably. I'm not sure how many of you are aware, how many are not. But it also means if people have a habit of binge eating and putting on weight, I mean, this is newly been approved to treat that condition because Vyvanse helps to reduce the appetite. So Vyvanse is one of the most popular drugs right now. It's probably, I heard that the ADHD drugs are actually taking up a huge market because of the explosion in the adult ADD diagnosis and the treatment aspect, and people are worried about the abuse potential of it. So basically people would like to prefer the drugs that have the less risk for abuse. So naturally they go for the drugs that are basically prodrugs, so they cannot be taken out and snorted or used for any other purposes. So the advantage of the Vyvanse is that when you take a Vyvanse, it's an inactive component. Goes into the body and breaks down into the active component and releases slowly into your system. So it kind of works for 8 to 10. Technically they say 12 to 13, but it's variable. So the idea is,
by its formulation, it becomes an extended release type of drug. Is that what you're explaining?
Yes, it is a prodrug that's basically broken down into the active drug, and then it can be used. So there is a couple of new ones came in called Quilachew. It's like a Quilavant. Quilavant is a liquid. It's an extended release Ritalin. Quilachew is a chewing tablets. So basically like people who cannot swallow or doesn't want to sprinkle because of the sensory reasons, And if they like I think it's a banana flavor, I could be wrong, but you have to look it up. So I think they came up with something called Quillachew. Quillachew is basically Ritalin you will be chewing tablet. And there is another one that came in called the apotensin, which is another interestingly extended release capsule that's again available from 10 to 60 milligrams. Extended release, supposed to work again 10 to 13 hours. And there is a brand new ODT tablet. It's called the orally disintegrating tablet. It's called the Adhd. Adhd is a amphetamine extended release. This is the first of a kind that there is a melt tab that's available. So people who can swallow, people who have trouble with difficulty with the don't want to like cheeking the medication, if you have any concerns about those kind of things, that would be a great opportunity to use this kind of thing, melt tab, because you put on the tongue, it goes into the system and starts working for you. The only disadvantage is that if you are a phenylketonuria patient, these are not recommended for people with phenylketonuria, just because of the phenylalanine is added into these kind of ODT compounds. So,
okay. So I get the impression that when you're talking particularly about ADHD medications, there's so much out there at this point that you really want to make sure you're working with a clinician that not only knows what's out there, but knows why and how one medication might work better or worse, or one formulation might work better or worse for your client, your patient. Can you tell us a little bit about, I know one of the things you talked about previously at our AET conference was GeneSight and how to help make decisions about what might be the better medication or what might be a medication to avoid.
Yes, it's a bit of a complexity. I mean, the key reasons is that the GeneSight reports, I usually use it for more for the antidepressants and the antipsychotics, because of the reasons is my concern is that how they get metabolized in the system. So for the listeners, basically, there is a website called genesight.com, spelled as GENESIGHT.com. And you can go and you can look it up under the information, and they have a graphic charts basically depicting like what the drugs look like in the green zone and the yellow zone and the red zone. It's basically like a traffic light pattern. Basically, the green is go, yellow with caution, and the red with extra caution. So it's not no-go, because the people have the perception that when it's in the red, that means you cannot use it. That's not true. The only reason you want to be caution with extra caution in the red, I'll just explain to you in a second. So the patterns were developed. There is a multiple receptors now being tested. With the time, we will be actually be seeing a personalized report that can be much more voluminous than what we're having right now. But I'll cover the basics of the Cytochrome P450 system, which is a kind of like our liver is our filter. What's where every drug goes, and then it breaks down into active and inactive metabolites. So there is enzymes that are produced to breaking them down are being influenced by certain genes, and these genes are being tested for. So these are basically known as the Cytochrome P450 system. In this, basically, like there is a majority of the drugs, about 40 to 60% are metabolized by a particular system called 2D6. The 2D6 is basically the main system through which drugs like Prozac or partly the Zoloft or Abilify, Risperidone, these are the drugs get metabolized. So there are 4 kinds of metabolizers we have available. So these will predict the way they respond at certain level based on the liver profile. That does not mean just because you are doing well on the liver profile, that does not mean the drug is going to work for you. It is eliminating one of the risk factors that is basically in terms of dosing wise helpful, but it is not making sure that because it's in the green, that does not mean that you're going to do well on the medication. So I want to be
really talking about eliminating risk factors when we're looking at the gene sequencing. I'm going to ask you to back up because you did make a point and I kind of disrupted the flow after you finished talking about ADHD meds. Maybe you can talk about the antidepressants and the antipsychotics and then go back a little bit to the gene.
Sure. So as you know, that the most popular ones are the SSRIs, and then the what is basically selective serotonin reuptake inhibitors, under which mostly the most common ones are the Prozac, Zoloft, Lexapro, Celexa, and then the older medications called tricyclic antidepressants, which is basically nortriptyline, imipramine, desipramine, Elavil, which is the amitriptyline, and the clomipramine, the gold standard drug treatment of OCD. And then there's there's SNRIs. These are called selective serotonin and norepinephrine reuptake inhibitors, under which basically Effexor, also known as the venlafaxine, Pristix, which is known as the desvenlafaxine, which is the metabolite of the Effexor, and then the Cymbalta, which is known as the duloxetine. And now we have a newer class, basically the newer drug called Fedzima, which is a highly more selective norepinephrine reuptake, but some selective serotonin uptake is involved with this. Fedzima is a brand new drug. And then there are newer versions of the drugs that came in the recent times. These are basically a medicine called vilazodone, also known as the Vibrate. It's an SSRI, which is it works on the partial agonistic property of the 5-HT1A receptor. In technicality, nobody really knows what are these, basically the receptors, what are the partial agonistic hit. When you're reading the label, they will say that the mechanism of action is unknown, but predicted that reduction in symptom of anxiety, depression is possible. So there is another drug came in called vortioxetine, which was labeled as Brintalex, which they're basically changing the label name now to Trintalex. The reason they're changing it to Trintalex is that the Brintalex gets sometimes confused with another anticoagulant, pretty closer name with the Brintalex. So they went and relabeled as Trintalex. So Brintalex, in addition to the serotonin uptake, has effect on multiple serotonin receptors. Some of them are agonistic at the 1A receptor, 5-HT1A, 1B, 1D. Okay, and the advantage of the vortioxetine is some effect on the memory. So it's an interesting drug to watch for. So moving on to the antipsychotics, the new drugs basically that came in recent market are Latuda, lurasidone, and the second one is the Sapphirist, known as esenapine. And very recently, about a couple of months ago, there is a new medicine called cariprazine, or known as the Rylar. The only difference between the older two and this one, there is another medicine came in called Rexulti, which is a sister cousin of the aripiprazole. So going into the cariprazine, the only reason it's interesting is that it has some effect on the D3 receptor, which is the dopamine 3. Most of the drugs are designed for dopamine 2, but not for the 3. So I'm not going to further details. It's a bit of a complex psychopharmacology. I'm going to leave you there and move on to the next topic. Whatever. Should I go on or should I?
Yeah, go ahead and go on. I think going back to the way you can use GeneSight to help figure out where the cautions are, and how to have a consult with a psychiatrist or a medical doctor.
Great. So usually the GeneSight report is designed in such a way that the fact is that it is collected by collecting a swab. The swab doesn't require any kind of blood or anything like that. It's a typical cotton swab we take and we rub it on the cheek, each cheek 10 times up and down. We put that in a label and then we FedEx back to the company, and the company makes the report come back to us within 3 to 5 days. And it's an electronic report that is generated and returns back to us, and we forward it to the family. The typical report consists of the psychotropics, ADHD meds, pain medications, anxiolytics, antipsychotics, and the mood stabilizers, and finally the MTHFR gene, which is becoming more popular in the recent times. So that is typically the comprehensive report is there. So I'm basically going to explain you some receptors, because if I go on into a much more detail, I have to go in for, I can talk about 30 minutes. Summary-wise, is the main thing I want to talk to you about is that there's 4 kinds of metabolizers are available. One is called the poor metabolizers. Poor metabolizers are ones that basically do not produce any enzyme that is needed to break down these medications. So what happens with these people is that assuming that you're giving a Prozac 10 milligrams, and I'm just making it an assumption because there isn't exactly, we really don't know what that exactly means. So if you are a poor metabolizer, the Prozac is not getting broken down. Because it is not broken down, it is kind of getting backed up in the system. So instead of, even though you give only 5 or 10 milligrams, it's in your system is working like a 20 to 30 milligram level within a few days. Because of that reason, it is not getting eliminated. You start seeing more side effects, because if you're not tolerating the medication, that causes to have more problems. So it increases your half-life in the system and side effects and the adverse events. So by knowing that, you can put the low dose and get the same benefit by using that. The second one is called intermediate metabolizer. The intermediate metabolizers are the ones who have 50% of the enzyme. So that makes it a bit tricky, because of the reasons is that the predicting the current level, the exact levels of how much the medicine in the system is a bit difficult, because it can work, it may not work, or we can tweak the medication, but usually we recommend is go slow. When you're going slow, you have a very good chance of not causing any problems. And the main is called extensive metabolizers. Extensive metabolizers are the people who basically metabolizes the drug as per the textbook. You know, they take the medicine, the drugs works exactly the way it should work. In terms of the liver, that's what basically I want to say very clearly. And finally, the one is called the ultra-rapid metabolizers. Ultra-rapid metabolizers are the ones who basically, the drug gets into the system fast, and they get out of the system very fast. So the problem with that basically means is that the efficacy and the duration of the drug that should be in the system is not getting achieved. So the best way to do that would be is either frequently dosing the medication, or basically eliminating the risk, because because it is breaking down faster, sometimes you may see more side effects before you see the effect of the drug. Or if it is an active drug is the most important, but not the inactive drug, you're getting the best response from the medication too. But also the difficulty is if you don't frequently dose it, you will lose the efficacy and the response of the medication, because it is getting eliminated quicker than usual. So this is the main profile of those. So there's a bit more tweakings that can go on and back forth about these things, but the other ones are usually the serotonin receptors, opiate receptors, which are basically OPRM genes is basically a receptor gene that is important for analgesic metabolism. The reason I'm usually making a bit of emphasis on these things is because of the reasons is that a lot of times when we take pain medication, for example, when people take pain medications, usually the hydrocodone or oxycodone, whatever these drugs, they get broken down into morphine in order to be effective. So when you are a poor metabolizer or ultra-rapid metabolizer, one of the things that's going to happen to you is that either you're going to get the effect quickly or you're not going to get the effect. And you tell your doctor that, oh, it seems to be not working for me, what do I do with it? And they look at you like either an addict or basically like, you are faking it. So the idea basically why I use that one is that the fact is sometimes by having this report in the hand and showing it to them, they can pick the right drug. Sometimes that can have a benefit because you can eliminate the option of a prodrug versus the active drug to help you to have the good analgesic effect for you. The same thing applies to some other meds we choose carefully. So that is the key factor of why we want to use it. But this is not fully, it is not been implemented at this point of time. It is to an extent is still inconsistent. Yeah.
Okay. So it sounds like it can the gene site or the gene work can help make decisions with regard to what might be more effective or work better over time, but it's not the be all end all. You still have to titrate carefully and work with your medical professional to make sure that things are going along smoothly.
Correct.
I'm gonna switch gears a little bit. I think it's fascinating to think about the liver metabolizers in this way. And just to give everybody kind of a quick review, you went through 4 different types of metabolizers, meaning basically people metabolize things differently. And they might metabolize it food, intermediate, extensive, which is kind of the textbook version that you talked about, or the ultra rapid. And so all of these might have an effect on the efficacy or the duration of the medication that is being trialed.
Right.
Okay. So I'm going to switch gears a little bit because we've got, I'm sure, a lot of educational therapists listening in. How have you worked with an educational therapist? How do you find that educational therapists can help you and help clients with regard to paying attention to medication and the complexities of it?
Well, the thing is that psychiatry is a very collaborative process. That's the way I always look at it. Psychiatry is not something you practice in a room and then you just see a patient, you send them out. I mean, the collaboration is critical because the effectiveness of medication, compliance about the medication, whether a lot of different aspects, which basically sometimes they are uncomfortable discussing with me, sometimes get discussed with the therapist. So having that kind of an open communication, sometimes very helpful to review, whether the medications has been taken properly or medications as having any proper, there's certain side effects. Sometimes they're very uncomfortable discussing with me, but they're very comfortable discussing with the therapist. So sometimes having that kind of a connection and a communication always helps to improve the compliance and the efficacy and picking the right medication for the patient, so that we are not missing out on some other factors of compliance of the medication. Number two, my concern with education therapists provide a very valuable information because of the reason is that everything sometimes cannot be covered in a medication session, which is sometimes no more than 15 minutes, at the most 30 minutes. So my point of view is that when somebody's seeing someone in a weekly sessions, they can see whether there is any change because of the added medication, no change, or basically things are going worse, or whether there are slight changes. These are all some of the things they observe on a regular basis because they're meeting on a regular basis, which is the most important information I'm looking for. And also sometimes certain side effects they cannot recognize. Sometimes you all can recognize, saying that looks odd to me, that doesn't seem to be part of his personality. Then you can get back to us and say, well, I'm seeing these changes, is it the right things or not? So those are the kind of things I'm looking when I'm working with so I usually tell them that please call me and tell me if you're noticing anything odd or not going well, or any risk factors.
Right, and obviously you need a communication consent to do that, but I know you're one of the few psychiatrists around the country who will invite educational therapists to provide feedback to them directly. Oftentimes it's the educational therapist that has to get in touch with the psychiatrist and kind of prove their mettle first. And then the collaborative process can proceed. So maybe you can give us a kind of a specific example. Obviously, psychiatrists tend to be harder to get a hold of. I know that you work very effectively with Cheryl Pruitt's group in Atlanta, and I think you have a shared process in terms of print communication, email, as well as phone call. Maybe you could just give us a quick example of how you guys work.
Well, our communication goes this way: is that if they have a particular case, they feel like they're in the crisis, they always call me and say, "Hey, is there a way you can see them quickly?" So I will either see them at the end of the day or the very next day, based on the urgency level. And we have a once a month rounds. We basically meet as a group, and then we go over the cases we are basically being involved in treating. The reason I do it is that the fact is that the one meeting is worth multiple phone calls for me about multiple patients, because it's actually saving me a tremendous amount of time and energy, because I am providing the right support for the education therapist. So they actually are extinguishing many fires for me, before which I have to deal with it when I don't have an effective collaboration therapy. We are seeing some really serious, difficult children, which basically requires lots of care. These are, in the olden days, these are inpatient care patients, which are basically now existing in our outpatient practices. So my idea is that the fact it's for some selfish reason, it is for me to, when I'm answering their phone call, I'm actually accomplishing a lot more, because of the reason is that once they know when to call me, how to call me, we establishing a very effective communication. They know, they are reassured that I'm available for them, and the opposite that too. My point of view is that that's what we established, and we were able to work with these complex children. So they do know when to reach me and what to reach me for, and when there is a crisis. So I think the establishing that relationship with most of the therapists, that's what I try to do with all my patients, because the reason is that I think by sitting in my office and trying to treat in those minutes, just talking to the parent is not child psychiatry, is at least the way I look at it, or the adult psychiatry, because it's called multidisciplinary approach.
Right. And one of the things you've talked with me about previously is on that front end when you're building a diagnosis and you're thinking about different types of targets. You talk about the pharmacology target, the therapy target, any other intervention targets. And one of the analogies that you used, which was so helpful to me, was the house of cards. I'm wondering if you can just briefly describe your house of cards analogy, and then we're going to go into the case so that we can illustrate that a little bit.
Yeah, I think the point of view is that the fact is that when a patient comes into the office, the primary goals are fundamentally three for me. How can I effectively stabilize him? How can I use all the tools that are available that we can utilize so that the patient get the maximum benefit in a short amount of time? Because most of the patients come to us in a huge distress, we want to make sure that we help them to stabilize so they feel there is a hope for them moving forward. So typically the main goal for me is that the fact is that somebody comes in with ADHD, anxiety, and mood, I start with the mood. I feel like mood is like the basement. Without the basement, you can't build the rest of the house. So targeting the mood is the most important when you're coming in, because once the mood is stabilized, once the anxiety is stabilized, I feel like the ADHD is the last deck of cards. That's what I was explaining to Laura, because basically ADHD is more or less like, just you put on a medication, you get the effect or not getting the effect. But the mood and anxiety takes some time to get that effect. By adding the ADHD in the beginning, you basically sometimes can exacerbate the anxiety and the mood. So you need to be very careful about the fine-tuning of these things.
Okay, thank you. Okay, for those of you listening, I'm going to read through this case. We do have a visual slide for you to look at just to hit the highlights, but I am going to read through the case. So this is a student that I've worked with previously. His name is Scott. Of course, that's a pseudonym. He's a 21-year-old college student, and he's been referred for educational therapy with the following concerns: procrastination, motivation, and work completion. He has a history of diagnoses around social disconnection, including a nonverbal learning disability, and sensory integration challenges, which are primarily associated with sound and texture. At the age of 15, a neuropsychological evaluation indicated deficits in inferential reasoning, identifying social cues, and discerning social nuance. He was also described as showing deficits in processing speed, executive functioning, written expression, reading comprehension for inference. Formal diagnosis at that time, at the age of 15, was a learning disability NOS and generalized anxiety disorder. At the age of 21, he did have a complete neuropsychological evaluation, which detailed the realities associated with diagnoses of ADHD, primarily inattentive, with a slow cognitive tempo, which was mentioned specifically. He was also diagnosed with persistent depressive disorder with anxious distress, and that LD-NOS, similar to before, was associated with processing speed, synthesis, and organization of information. His challenges were particularly apparent when he was faced with lengthy reading and open-ended writing tasks. So upon presentation to me, task completion and engagement with full-time course load at a local university was our priority, and that was where we began our work. Scott historically has earned A's and B's when he completes courses. He describes himself as an all or nothing kind of student in terms of meeting the expectations of a class. So Scott was connected to a psychiatrist with whom he appeared to have a very stable relationship. As educational therapy began, Scott was taking 40 milligrams of Vyvanse and 2 20-milligram tablets of Prozac daily. Medication did not come up during our sessions at all through the successful completion of 1 semester of work. I was feeling pretty good. During our second semester, however, Scott reported difficulties with headaches and motivation, specifically around the journal writing assignments that he had for 1 course. He later told me that he had decided to stop taking his SSRI, the Prozac, because it really wasn't doing anything. That was his quote to me. He proceeded to apply for an incomplete subsequently in that one course, and he struggled to meet the demands of his other 2 finance courses as well. Despite having so many questions associated with this student, as you can imagine, it was his challenges around motivation and task completion as it relates to what became apparent as simultaneous to coming off of the Prozac medication. I don't know if they're directly related or not. So I'm particularly understanding not only how I might have shared more different information with the psychiatrist, but also how I might facilitate Scott's understanding of himself and his habits as he perceived the one medication not really making a difference until it obviously did make a difference. So there we are. That's the case. Tell me a little bit about why might have been the decision with Prozac and Vyvanse together, where the mood destabilization might have impacted that house of cards, as you so nicely put it. And I'm just going to let you make some comments from there.
Yeah, well, it's interesting that remember one thing, we have a one added layer to it, which is the nonverbal learning disability. People don't realize is that the fact is that when you have a kid who have nonverbal learning disability, you are basically adding a lot of anxiety with a lot of perceptual distortions he's experiencing on a day-to-day basis with his functioning from every movement in his life. I mean, he's not reading the verbal cues, nonverbal cues very, very well. So this is basically going to affect his level of anxiety. So remember one thing, the Vyvanse, I always tell, it's like a zoom lens on a camera. When you give them somebody, you can focus. When you don't give them, they don't focus. So the question is that when you're defining ADHD, how would you define ADHD in this kid? How would you describe him as there is a lot of social learning, there is a lot of emotional learning is involved, in addition to the anxiety and the depression. So I'm not so sure, whether I would be starting with the Vyvanse as my first choice. I'm more interested in stabilizing his anxiety and depression, and then looking into the options of something more relevant to improving its social cognition and improving the attention. Because my main concern with that part, the reason being is that the fact is that the idea is that you want to improve his depression state, because his depression state is partly came from his own sense of despair that he's not functioning well, and also from the learning process, which involves not only about the verbal aspects of it, but there's also nonverbal aspects of it. So I think the supporting with the right kind of therapy and the other services, along with the picking the medication that would fit his right profile, would be the right choice to start with. I have no qualms about Prozac as a first choice. If he's not ever tried any medication, I would go with the basic SSRI. If he's having more than, the thing is that we have to look into see whether that is, we're getting a better response with the Prozac. If not, what are the options and meds we were basically trying to target? So there's definitely, these kids have a huge anxiety factor playing a huge role into it. Prozac can be helpful, but in addition to that, we have to start doing some other measures to control their anxiety down. And then we need to work on the organization aspect. Go ahead, I'm sorry.
So how would I either help him talk about or help him ask questions of his psychiatrist, or how might I ask questions of his psychiatrist to help Scott better understand that in fact there was a difference? And even if he didn't feel depressed or didn't feel particularly anxious, there was something going on that the Prozac was definitely making a difference.
Correct. So sometimes Prozac can, after a while, stop working for children or adults. Sometimes it's called, sometimes, it can actually lessen the motivation. This is something everybody knows. This is not something new. I'm talking about it. So the key things you need to would be interesting would be is that you remember one thing. Sometimes anxiety is the drive that basically makes us work. When we have a bit of a worry in our back of our mind, we actually perform very, very well. If I take away your entire anxiety out of it, just you are a pure ADHD kid, then you don't care about anything anyway. You don't care. So point is that the fact finding the fine balance between that anxiety and attention is the critical factor. So I think the key is that the titrating to the right dose to watch what is his motivation is like and what can be helpful with the motivation is the main thing. Sometimes stimulants are the drugs that are used for motivation aspects, but there's a lot of other options also out there that can be beneficial, because the problem with the stimulants is they work, they don't work. What I mean by that is they're in the system, they work. When you take them out of the system, they don't work. But we need to stay motivated 24/7. We just can't be saying that, okay, when I'm sleeping, I'm not motivated kind of thing. I mean, you have to get up at 6 o'clock in the morning and you need to get through your day. So the key questions is that we need to sort out whether this motivation is part of his general system or is it a part of the depression that is affected his motivation. And that is basically what basically would, kind of like make us to make a decision what would be the right med to add.
Okay. So one of the things that you're talking about, that organization of system versus motivation, I know one of the things, he was always very, and still remains, motivated to get to class. He has a very regular routine. And as long as he has that external obligation, he'll get up and go. And yet on the back end of it, if there is an assignment that's looming, if there's particularly writing assignments where he has to come up with some expressive language things and turn his thinking into words, he gets anxious and he shuts down, and he'll tend to either go to bed or just sit and watch TV. So there's low arousal there, but he'll still get up and go to class the next day even though he's missing the assignment. So there seems to be a disconnect there.
Correct. So technically, the way you were explaining, I would explain to my patient would be the following: is that the fact, so think about this way. I have, think is that, I gave him attention medicine. By giving the attention medicine, only thing I accomplished him is that I made him hyper-focus on things. But I also making him hyper-focus on his anxiety because he's worried about the assignment rather than doing the assignment. So the problem we are dealing with this particular kid, or any kid would be, is that the fact is that he does not know how to break down his assignment into what parts and how to accomplish. Because he's not able to do it, you basically are saying that, oh, Vyvanse is not working. Vyvanse won't work. Vyvanse will only help you to think and focus a bit faster. But beyond that, it is not going to do your assignment. You still have to come up with the strategy of how you're going to do the assignment. Right.
So the executive aspect of executing the assignment is still paramount. And so what I'm kind of interpreting here is that while he stopped taking the antidepressant and continued to take the Vyvanse, that we kind of took the foundation out of that house of cards analogy, and as his mood destabilized, the Vyvanse wasn't doing what it had been doing before because he was then hyper-focusing on the anxiety, we can assume, rather than the just get it done kind of approach, despite all the executive function tasks that we had worked on. They just stopped working.
Right.
Okay, that's really interesting. So along the same lines in terms of habit and routine, when you are taking multiple medications for various different things, how might they interact? And is there thought given to when you take which medication to get maximum benefit, maximum effect, things like that?
So re-explain that a bit more.
So the question that I have on my sheet are how do medications interact? Are there side effects or in contraindications? Do we need to think about dosage from a procedure of time?
Correct. So the simple example I'll give you is the following. It would be like, just like the gene side thing we talked about, right? I mean, nowadays, the FDA warnings and the FDA website, when they're releasing the prescribing information, they have some of these already put in there. So it's interesting to see that. For example, like somebody came to you on Prozac and their depression is not getting better. So I want to add the Abilify for his depression, assuming for a quick second. I'm giving you a scenario.
Mm-hmm.
So my point is that let's assume that they're just taking the Prozac 10 milligrams. I'm adding the Abilify. Not so really a big deal, because of the reason is that I can increase the Abilify dose. Assuming they're taking 40 milligrams of Prozac and I want to add a 5 milligrams of the Abilify, that's good. I can add up to 5 or 10 milligrams, because beyond 10 milligrams, we don't recommend adding when you're on a higher dose Prozac, because Prozac inhibits Abilify breaking down. So the key reasons why it's higher than what you prescribed for. So the idea is that the fact is that that's the main thing we watch for. So when we're combining certain drugs, sometimes we can take it to the advantage by adding low doses of each to potentiate the effect, or basically by increasing, decreasing, we can play around this way. Like another way of saying to you, I can increase the Prozac and decrease the effective dose of the Abilify, because of the reason is that I'm doubling the Abilify without affecting the the Prozac dosing, and the opposite I can do also. So that is the key thing we always say. Let's say that I want to taper off the the Prozac out of the system, then I need to go with the regular dose on the Abilify. So that's
so this is about potentiating as well as perhaps transitioning.
Correct. Right.
Okay.
So that's the next thing is basically like in terms of the side effects, we always watch carefully, because of the reasons is that each class of drugs have a different kind of things. For example, SSRIs up to the age of 24, they have the suicide box warning. So we are very careful about assessing to make sure whether they have any pre-existing suicidal ideations, whether they're getting worse with the medication or they're about getting better. Because the idea is we add SSRIs to improve the suicidal ideations, but while they're taking the medication, you notice any change in activation level, that means that his impulsivity levels or his restlessness levels or his increasing thoughts of suicidality, then we actually ask you to stop the medication. If the opposite, then we are basically seeing the effect of the medication. So with the Abilify-like medications, of course, antipsychotics, we do monitor for the metabolic side effects, because of the risk of the metabolic side effects are pretty higher. So, usually like what we usually say is that there's a lot of drug interaction checkers nowadays you could use, whichever you like, and then that also gives you potentially the risks, benefits of adding and taking certain medications, because nowadays many people are on multiple medications from multiple doctors. So I always encourage you to all to look at that. So make sure if they're not, always encourage your patients to make sure they make all the list of the medications. And, a lot of times, for example, I'll give you a very simple example, would be the grapefruit juice. A lot of people don't think there's a problem with the grapefruit juice, but there are certain medications. If you're drinking grapefruit juice every day and you taking those medications can go through the roof.
Yeah,
So,
they got some serious issues.
So I think the most important thing as an education therapist, you could help these patients educate about, write down taking all the medications they're taking and take it to the doctor, so that he has each and every one of them on the list, so he knows what can be combined. Because sometimes people do is serotonin supplements. They don't even know that they have it.
Right, and that's a nice task for, it's a list-making task that educational therapists like to do if they're working with a child who has some executive function issues, but it serves a collaborative purpose as well, so that as a family moves to a consult with a medical doctor, they're actually prepared in a different way than going in just with the question marks hanging over their head. The educational therapist can actually help them prepare to ask the right questions or listen for different information that they might not even be aware of is valuable.
Yeah.
I am being mindful of the time, and I've got one more question to ask you, and then we are going to open up to Q&A. And the question that I have is related to the role that parents can play in terms of treatment considerations, particularly when you've got older adolescents or adult students where technically they're kind of more independent and on their own, and yet they're living at home or the parents are paying the bills. What kind of suggestions do you have in terms of treatment considerations for parents?
My point of view is that I always believe in more than one feedback, because my concern is that a lot of these teenagers and young adults are not really that accurate. They're not as mature as they think, especially when they're coming into treatment with us, especially when they're going through the episodes of depression and anxiety and some of these significant issues. So their maturity levels are not accurate to accurately describe their symptoms and their stresses and other things. I preferably encourage most of my patients, and I always maintain a continuous contact with the parents, because they are at the age where they share some things by text and other ways to their parents, but they don't share anything with us. So I always tell the parents, if you're noticing any red flags, or if you're noticing any concerns, please do not hesitate to contact me, and always try to convince the young adult to sign a consent so that I can speak with the parents. I will tell them, I'm not telling you about everything you need, you don't want to tell me. Like, for example, if they have using a brief marijuana or smoking, they don't want to share me with their parents. I'm not going to share with them, but I want that communication from that side to be open to me, because if I have concerns, I can call them and say, hey, hi, how is he doing in your perception? So at least they can share their perception of what's happening, which helps it tremendously in terms of making the adjustments to medications. So my strong recommendation always been to involve the parents as much as possible, and at least until they're mature enough and you feel convinced that they are capable of reporting their own symptoms.
And oftentimes, particularly the resistant students, the older students who may or may not be telling their parents as much, they actually may be telling their educational therapist more, psychotherapist more. And so as you talked about, that more than one feedback loop, that is valuable. And oftentimes, because I work primarily with older students, I will communicate with the parents that I do have consent to speak to them, but I will always ask the student what is appropriate to share and what is not with the parent, not necessarily with the psychiatrist or with the psychotherapist.
Absolutely correct, yeah. So my point of view is that just to clarify the statement, what I made is that the fact I don't share any information when I'm calling the parents.
Right.
I'm obtaining the information from them, how they're perceiving how the student is doing. So I collect that data and I compare the data patient is presenting. So I have a two-pronged information before me of how they perceive and how they're perceiving him and how he perceiving his change. That helps me to make my decision about the meds.
Okay, thank you. All right, we do have a couple questions already up on the Q&A board, and I'm going to ask the ones that I think are probably most relevant to everybody who might be listening. If there are questions that you're asking and they don't get answered, we might answer them by text outside of this the 7 minutes we have remaining. So the first question is from Kathy, and she says she's wondering if you can talk a little bit about attachment disorders and a child's ability to attend or approach to medication or not for ADHD.
Attachment disorders, as you know, are very unpredictable in terms of their impulsivity and their regulation, and also related to their So when we see these kind of children, we have to be careful about what we choose as the targets of treatment, and then we need to start working on those aspects of the treatment. Typically, I like non-stimulant medications like clonidine and Tinex to start with, and then if I need it, even for the focus reasons they need to use as stimulants, I would certainly be happy to add if we're using the ADHD medications. The reason for using the combination some other times in these kind of kids, because some of these kids are under-aroused and some of them are hyper-aroused. There's basically, you can call it like more like a engine running high or engine running low, or it's a sensory dysregulation we basically notice with them. So there is a lot of adrenergic output in these kids. They are like, so what we'd like to do is that the fact is that we want to bring that arousal a bit down by basically putting them on clonidine and Tinex, which helps them to be a bit more regulated in terms of hyperactivity, impulsivity, and we focus on the stimulants as an option to see if there's a benefit from the focus aspect of it. So if they're showing any signs of irritability on the focus medications, then we go back and look into see whether we're missing any targets for anxiety, depression, or any other aspects before we re-add back some other stimulant medication. If we don't find anything, then we'll switch between the classes or short-acting versus the long-acting to help improve their participation in terms of school.
Okay, thank you. There's another one here from Lakeisha, and she is asking if diagnosing ADHD is based off of questionnaires, how do you know which medication to give a patient? And she proceeds to elaborate a little bit there. Many times I work with students who are on medication for ADHD, but they don't seem to be working. So they keep getting different doses or different meds. It's like a trial and error. Shouldn't there be a more efficient and effective way of knowing the best medication?
Great. So to answer the question is like the best example I can give you is that how many times we have taken our kids to pediatrician, and he will do the strep test on our children, and then he will write, oh, by the way, I will start with him on amoxicillin. I will wait until the culture report comes back. I will switch to a different one. Even let's assume that strep test came positive. If amoxicillin doesn't work, he will move to the next one, but he won't run the antibiotic sensitivity assays to decide which would be the right medicine to start at the first time. So the bottom line, what I'm trying to say, using this example, is that the fact is that the probes we have, some of them are available, called COMT gene, and also ADRA2A gene. These are the two genes, along with the metabolism, which is basically, as I explained, on the cytochrome P450, and a few other genes are being looked at. But I don't think we still have a very accurate way of knowing it, because ADHD is such a complex disorder. A lot of kids with executive functions may look like ADHD. A lot of kids with anxiety can look like ADHD. So when they're picking these medications, sometimes some will not do well on the long-acting ones, whereas they need a short-acting one. Some needs the long-acting instead of the short-acting, because they're basing on their ability and their organization ability. Because a lot of times these kids are not very organized children. They can't take multiple dosings multiple times to remind themselves to take. So they take it when they want, how they want. So there is a lot of inconsistencies in it. So I think the psychoeducation, and again emphasizing and providing them with some tools how to remind themselves to keep taking these meds, sometimes is the best effective way of noticing. If you still feel like one family of drugs is not doing well and he needs to switch to the other one, certainly that's worth to take a look into it. Other option is based on the absorption. Some of them are delayed release, some of them are immediate release, some of them are 50-50 releases. So it's technically can be a bit more tricky, but we can use those ways to help find the right drug for some of these kids.
Mm-hmm.
I probably gave a long answer, but I think there's no way of knowing exactly what it is. Yeah.
It informs our arsenal of knowledge.
Right.
Okay, we have two relatively related questions. They're both related to ADHD. So I'm going to ask both questions together. One is about a 15-year-old client who was treated with lamotrigine for anxiety and depression. She was just diagnosed with ADHD, inattentive type. The question there is, what would be a good medication treatment to consider? And similarly, the question from Karen is, typically stimulants are contraindicated with children who have Tourette's. What do you recommend for children who have significant ADHD with impulsivity?
With the Tourette's or without Tourette's?
So with Tourette's.
Okay. So the first question for the lamotrigine is there's no right and wrong answer for that. I think basically the question would be is depending on the doctor's choice, either they can go with the Adderall or the Ritalin. I like to usually start with the Focalin in these kind of cases, because of the reason is that Focalin is a pure metabolite. There's nothing to break down. Second thing is that I feel Focalin is a bit less anxiety provoking than the others. So I like to start with the short acting, and then I kind of switch them to the long acting, because if they have an adverse side effect, it won't last long. So they have a chance of trying it out and then making a decision about the long actings. I usually try not to start long acting on kids or adults in the beginning, because if they become jittery, they're going to be jittery for 8 hours. That's a pretty unpleasant feeling to be on. So I always start with the short acting, and based on what the results is, then I will look for the long actings. To answer the question about the Tourette's and the ADHD, my point is there is no absolute contraindication. When I trained, it's usually the absolute contraindication, but basically you can't use stimulants with kids with Tourette's. Nowadays, kids with Tourette's can be on any stimulant medication as long as their tics and other symptoms are under reasonable control. So usually the non-stimulant ADHD medications like clonidine or Tinex are the first line of drugs they use for ADHD to suppress the tics. But if they're still having a lot of difficulty with the focus, you certainly can add this stimulant as long as their OCD and anxiety is somewhat better controlled, if they do have those comorbids.
Okay. Well, it is 1 o'clock. I have one more question that was posted, so I'm going to ask it. I have a 7-year-old who will not take a risk. I suspect ADHD. Her brother and father are in treatment for ADHD. I've tried typical executive function approaches with her. Nothing works. This is affecting her learning to read. She does not have any other apparent reason why she's not learning to read. So I think the implied question is, what might be the relationship between risk-taking and a potential ADHD diagnosis? Or do we have to start below that in terms of some mood stabilization?
Well, risk-taking is basically, remember one thing. One of the main aspects of the attention deficit is the impulsivity. If she's not an impulsive child, definitely you might want to take a look into some of the anxiety aspect of it, because one of the reasons that the young children can be a lot more shy and a lot more introverted. They may not come across as ADHD. So one of the things is that the fact is you certainly can look into the assessment of the anxiety aspects of it. If you don't see the anxiety aspect, it's the only thing that is really is attention deficit is the only thing you worry about. As long as you don't see any learning disability with the children, by putting them on the ADHD medication, you may improve the focus a bit better, but you won't solve the issue, because of the reason is the main issue here is that whether there's any learning way, the learning patterns, like a reading disorder or something those way that's getting in the way, that needs to be ruled out. So my thought process is I rule out anxiety, I rule out definitely the attention issues, and I rule out learning issues. Those are the ones I would look into before I would start medicating the child. Because one advantage, when the younger kids you're treating, you can put them on fish oil. There is a form of fish oil called Vayarin, V-A-Y-A-R-I-N. This is a medical supplement or medical food. It's a fish oil with phosphatidylserine, which is available on market, and doctors has to write for it. It could be any doctor, a pediatrician or anybody. 2 capsules a day can be given, or just you can use the fish oil with. That's also is an option, because there is some studies basically showing improvement in the ADHD symptoms with the fish oil. So you can always start with a conservative measure while you're looking for the rest of the things, and then based on that you can continue the treatment of what medication is accurate for this child.
Wonderful. Thank you so much, Dr. C. Thank you, everybody, for listening. I don't know if Nan has some wrap-up conversation to provide, but we are at the end of our webinar for the Association of Educational Therapists. Thank you so much.